Good afternoon and welcome to the Child Neurology Foundation's 2017 webinar, Let's Talk About Sudden Unexpected Death in Epilepsy, or SUDEP, a conversation with parents and doctors. My name is Cindy Wright, and as a SUDEP advocate, I've been working with the Child Neurology Foundation on their 2017 educational initiative, and I will be moderating today's webinar. We are excited to bring you today's webinar featuring a panel of national experts that will help us to better understand the causes of and the risk for SUDEP, strategies for families that can be used in talking with medical providers about a child's health risks, and provide information on resources available to families. Before getting started, I wanted to briefly highlight who the Child Neurology Foundation is for those of you just learning about the Child Neurology Foundation, as well as our work to support SUDEP awareness. The Child Neurology Foundation is a national organization that serves as a collaborative center of education and support for children and families living with neurological conditions. Each year we select primary education initiative, and this year we selected SUDEP. In addition to hosting this webinar, as part of the effort, the Child Neurology Foundation hosted a sold-out symposium at the Child Neurology Society annual meeting last month to educate professionals about SUDEP and to highlight the importance of SUDEP disclosure with families. We also created 2 resources to support the SUDEP initiative. The first is a brochure for families to assist when considering purchasing a seizure alert device. The second is a resource card for physicians to aid in initiating difficult conversations, including SUDEP. At the end of this webinar, we'll be able to provide a link to download these materials. The Child Neurology Foundation would like to thank our sponsors for supporting this initiative and the webinar. None of this would have been made possible without the amazing lead advocacy partner, the Danny Did Foundation. We would also like to thank our corporate partners, Lundbeck, Greenwich Biosciences, and Synovian. Our other advocate partners supporting the webinar include the Epilepsy Foundation SUDEP Institute, Dervais Foundation, Finding a Cure for Epilepsy and Seizures, or FACES, the Lapham Family, and the Tubular Sclerosis Alliance. Now it is my pleasure to introduce today's fabulous panelists. Our first panelist is Dr. Jeffrey Buchalter, and he'll be providing us with clinical aspects of SUDEP in children. Our next presenter is Dr. Sarah Freebert, who will discuss the art of bidirectional healthcare communication, talking about the hard stuff. Our third presenter is Tom Stanton from the Danny Did Foundation, who will talk about minimizing SUDEP risk, how to advocate resources that can help. And our final speaker is Margaret Story, who will provide the family perspective on living with the knowledge of SUDEP. Our presenters will speak for approximately 60 minutes, so feel free to send your questions through the webinar, through the chat function on the left side of your screen. Only the presenters can see your questions, and they are not made public. I will present these questions to our panel at the end of the call. We want to hear your voice, so please ask questions, but remember to keep your questions general in nature. We cannot provide information or medical and treatment advice for your specific situation. There will also be opportunities throughout the presentation to participate in polls so we can get to know our audience. You will see a slide with a poll question, and then the following slide will allow you to submit your answer. We are very excited to hear from our speakers, but first I want to share with you some information we gained from a survey of families that highlights why SUDEP education is so important. In August 2017, the Child Neurology Foundation partnered with several advocacy organizations to survey caregivers of children with epilepsy to determine knowledge and communication about epilepsy between medical professionals and families. We sent a 19-question survey to caregivers of children with epilepsy and received over 1,200 responses. Because our survey was emailed through the epilepsy advocacy organizations, the findings are not representative of the general epilepsy community, as these communities are typically more educated about their condition, and as you can see by this graph, are already seeing epilepsy specialists. We know from research that many families with epilepsies have yet had the opportunity to meet with a neurologist, and most don't even know that epileptologists or epilepsy specialists exist. So now is our opportunity to take our first poll. So the question, don't vote, you can't vote yet. How much do you worry about the risk of mortality as it relates to epilepsy and seizures? So now you can vote. Not at all, a little, or lot. Sorry, there's a typo there. It should be a little. Give a few more minutes for some votes to come in. And okay, we'll go to the results. So no one doesn't worry at all. 60% worry a little and 40% a lot. So very similar to what our survey results told us. Almost all caregivers are worried their child will die from epilepsy. And this is true even for families that do not describe their children as having frequent seizures or generalized tonic-clonic seizures. In our symposium last month, we explained to medical providers that just because a family does not ask about SUDEP or mortality does not mean that they don't worry about it. We also believe for families who are at low risk, discussions around risk level may actually decrease worry and fear. Our survey found that respondents felt informed about epilepsy and 91% had heard of SUDEP. This is great progress with regard to awareness, as even 5 years ago, only 79% of families had heard about it. But where are people finding out about SUDEP? The vast majority of people learn about SUDEP on the web or through patient advocacy groups. Only 14% learn about SUDEP from their epilepsy specialist or neurologist. But the next place families go for information is their neurologist or epilepsy specialist. So are these medical professionals having the conversations? According to a 2012 survey of US and Canadian neurologists, they rarely discuss SUDEP with all of their patients, and the majority of respondents discuss SUDEP with less than 50% of patients and caregivers. Only 7% discuss it with nearly all their patients. The Child Neurology Foundation is currently supporting a study to determine if this statistic has improved since 2012. In our survey, over half of families believe that knowledge makes a difference in care. We hope the knowledge you gain today will provide you with information to help ensure you are giving people with epilepsy the best care possible. And now I would like to turn things over to our first presenter, Dr. Burkhalter.
Thanks, Cindy, and I want to thank the Child Neurology Foundation for allowing me to participate with you today in this webinar, and to everyone on the line for taking some of your valuable time to learn a bit more about SUDEP. My charge is rather large, and so what I'd like to do is touch on these areas with the hope that you'll ask more in-depth questions when we have the opportunity. So these are the topics that I'd like to discuss. We'll begin with definitions, then talk about what is the risk of a child dying with SUDEP in terms of the epidemiology and risk factors, what are preventative strategies, and a brief bit about what's happening in SUDEP research. So in terms of definitions, these came out really 1997 from two separate groups due to a rise in interest in the epilepsy community. And the definitions, as you see on the screen, is a sudden, unexpected, non-traumatic death in a person with epilepsy without a post-mortem exam, an autopsy, evidence of structural or drug-related causes of death. And in order to be more specific, several categories of SUDEP were defined: definite, probable, and possible. The biggest issue being the use of autopsy post-mortem examination to make sure there was nothing else going on. In 2012, as the field moved along, it became clear that a more detailed definition was required, and a group of investigators who've been prominent in that community, led by Dr. Lena Nasheff and Elson So, created the so-called unifying definitions of SUDEP. And as you see here, in addition to specifying with or without autopsy or without witness, there were other aspects that were now included. For example, prior to this definition, if someone was found with the face down in a pillow, it wouldn't be described as SUDEP necessarily, rather suffocation. But we strongly believe that it's the seizure that leads to SUDEP and suffocation. So that was added to the definition. Now, in terms of epidemiology and risk factors, there's a fairly large body of information that I'll try and highlight for you. This is from a review article published by Dr. Orrin Devinsky in 2011. And what you see is incidence per 1,000 person years on the vertical axis and different categories of folks on the horizontal x-axis. On the left that you see, most left, you see children, and from this one would assume that the risk is extremely low. This has been something of a double-edged sword in that, yes, it is low, but as we'll see in the next slide, it's a very significant number. As one moves to the right, you see the next category, population-based cohort. And again, this is all comers in all settings for people that have epilepsy. As we continue to move to the right, the incidence goes up, and as you would expect, those who have seizures which are not controlled with medication, refractory epilepsy, and those who are in surgical epilepsy clinics, have the highest incidence. So depending on the clinical situation and age, you can get some insight into incidence. Now, this is an article published in the last few months. It is a very important article because prior to this time, the belief was that children had a significantly lower incidence of SUDEP than adults. This study was performed in Scandinavia, where all the death certificates and then medical records could be investigated. So it's the really most detailed study that's available. The bottom line of this investigation is that the incidence of SUDEP in children is pretty much the same as it is in adults. And therefore, that should, number one, encourage us to discuss it in the office, and number two, be as aggressive as possible when seizures are not controlled. This slide is intended to demonstrate that there are a variety of non-epilepsy related deaths in children with epilepsy, and by far the greatest is pneumonia. This has been demonstrated in the studies that you see listed, and is a very consistent finding. The significance of this is that pneumonia is potentially preventable, so that we must pay extreme attention and care to children and adults who have pneumonias and respiratory issues. In this slide is a summary of 4 studies from an article by Dr. Ann Berg, in which it is very clearly demonstrated that the #1 cause of premature mortality in children living with epilepsy is SUDEP. So there's really no excuse not to discuss this with care providers, and for us as care providers, not to discuss with our patients and families. So now we have our first poll question. What do you think puts children with epilepsy at greatest risk for SUDEP? A, lack of anti-epileptic drug therapy, frequent generalized tonic-clonic seizures, nocturnal seizures. And so please vote. But give everybody a few minutes, a few seconds. And results are still coming in. Just to see, so you know what I'm seeing. Choice A, lack of anti-epileptic drug therapy, is we get 9 votes. Frequent generalized tonic-clonic seizures, 11. Nocturnal seizures, 15. And there's the graphic representation. So the one that's identified most commonly is nocturnal seizures. The correct answer is C, generalized tonic-clonic seizures. This has been demonstrated in a few studies. The most prominent are here. On our left is that by Nilsson et al. And what it shows is that if you have, one has 0 to 2 per year as the reference value, having 3 to 12 increases the risk almost 4-fold, 3.8. On your right, Walczak et al., if no generalized tonic-clonic seizures is the reference, having 1 to 3 doubles the risk, and having more than 3 makes the risk 8 times. So even though it's very rewarding if someone's having 10 tonic-clonic seizures a year to reduce it to 4, that still leaves the risk 8 times greater than reference, so we must try and do better. Now, in the last couple of years, and you'll notice that a lot of the references are from the last 5 years, there's been some indication that we can be more specific with what kind of generalized tonic-clonic seizures. This is a paper that looked at various aspects of seizures in children and adults. And what you see, and I want you to look at the blue circle, tonic seizures. And you see that these are roughly equivalent in children and adults. Tonic meaning the ones where the whole body stiffens. Why is this important? And the answer is indicated on the next slide. This looks at risk factors. And a specific one, which I'll demonstrate later, is called postictal generalized EEG suppression. And what that means is that after the seizure occurs, the EEG becomes flat, suppressed. Type 1 is a tonic seizure. And what this first result demonstrates is that the likelihood of having flattening of the EEG is greater if you have PGES than not. The bottom part looks at early administration of oxygen. The answer yes indicates that if oxygen is given, the likelihood of having generalized suppression is lower than if it's not. So this is using generalized EEG suppression as a biomarker, and I'll mention that again shortly. Now, what about the issue of sleep? What this study indicates is that obviously on the left, most seizures that occur during sleep are not witnessed. But when you see that bar, that circle at 4 to 8 a.m., that's when the majority of seizures during sleep occurs. So this is telling us something about the physiology of sleep that we don't quite understand, that the incidence being much higher during these hours of sleep, creating risk. And the conclusion was those who died during sleep were more likely to have a history of nocturnal seizures than those who died while awake. Again, providing insight into who is at greatest risk. Now, this demonstrates the two studies in the literature which try to address this in children. The first was from 1995, and it looked at a residential school in the United Kingdom for kids with epilepsy and learning disabilities. There were no deaths while at school where there was an attendant in the sleeping area versus 14 deaths that occurred while the kids were home, suggesting that supervision helps. This is another study from 2005, which indicated that a person of normal intelligence, at least 10 years of age, or a listening device in the room, I'm sorry, the sentence after or is missing, reduces the risk of dying of SUDEP by 60%. So although these are not big studies, they're highly suggestive. What do we know about prevention? And I've made a list here. The first three, anti-seizure drugs, surgery, vagus nerve stimulator, all refer to interventions to decrease or eliminate seizures, particularly generalized tonic-clonic seizures. Take-home message is that the one thing that we know is the greatest risk factor are motor seizures, and anything we can do to prevent them is the most powerful means of preventing SUDEP. The fourth bullet, nocturnal supervision, we just talked about, and the suggestion that having someone know about if a child is having a seizure can prevent it. The next button is seizure warning devices. I need to be clear that there is no evidence that suggests that seizure warning devices prevent SUDEP. The thinking is that if one knows about a seizure occurring and can reposition the child or adult or do CPR, that will lower the risk of SUDEP. That's a logical extension that so far is without confirmation. The next issue is SUDEP disclosure, and that's the whole big issue of just discussing it in an open setting so that one can, number one, be aware of it, and number two, have a discussion about what other things can be done to prevent SUDEP. And finally, SUDEP guidelines, which I'll talk about in one moment. So the American Academy of Neurology, after a 7-year process, published guidelines for neurologists regarding SUDEP in January of 2017. Actually, I'm sorry, it was April of 2017. The first guideline says clinicians caring for children with epilepsy should inform the children's parents or guardians that there's a rare risk of SUDEP. Unfortunately, the guideline came out before that more modern study, that more recent study. So this rare is really an understatement. It should be more than rare. And in a year, SUDEP typically occurs in 1 in 4,500. It's closer to 1 in 1,000. The next recommendation guideline was that for persons living with epilepsy continue to experience generalized tonic-clonic seizures, clinicians should continue to actively manage epilepsy therapies to reduce seizure occurrences and risk of SUDEP. Again, always incorporating patient and family preferences on how this is done. And finally, based on very limited evidence that I showed you, persons with frequent, and I would say any generalized tonic-clonic seizures and nocturnal seizures, selected patients may be advised to have nocturnal supervision or listening devices. So these are now out there as guidelines for neurologists taking care of people living with epilepsy. Finally, last topic, what is happening in SUDEP research. Why do research? Two straightforward reasons. Number one, look for biomarkers, indicators of who is at risk and therefore who requires intervention. And second, the holy grail is if we knew what caused SUDEP in an individual, perhaps there could be a direct intervention. The upper portion of the slide indicates SUDEP research publications since that definition that we started with in 1997. And as you can see, the literature has exploded with publications addressing SUDEP, which is an absolutely fantastic kind of thing. And I'll just say in a political way, this is due to funding agencies like the National Institutes of Health, Cure, Danny Did, Epilepsy Foundation, and others. So this is funded research and why it's just so important to contribute. This is the biomarker that we talked about, postictal generalized EEG suppression. The arrow is where the clinical seizure occurs, and what you see afterwards is a flattening of the EEG. So this is PGES. This cartoon, if you will, tries to illustrate how a terminal seizure then results in some respiratory, cardiac, or brain dysfunction resulting in SUDEP. We just need to remind ourselves that the brain is connected to all the organs in the body. So it's conceivable and it makes sense that what happens in the brain affects the lungs, the heart, blood pressure, and so it's a complicated issue. Just to say in a summary kind of way, there is evidence that in certain people that cardiac, heart-related problems and specific mutations in genes can lead to death related to epilepsy. Similarly, respiratory changes are prominent when people have seizures, and the biggest study, called the Mortimus trial, looked at this, found that respiratory failure preceded heart failure in every recorded incident of SUDEP recorded in epilepsy monitoring units. And finally, there is the issue of genetic predisposition. It would be a heads up if we knew which genes were associated with SUDEP so as to be able to counsel those individuals. There are a whole variety of genes that have been found to be associated with SUDEP, predominantly in animal models. So with that, I just wanted to thank you for your attention, and I'll be happy to answer questions as best as I can at the end of the session.
Thank you, Jeff. This time, just a reminder to submit your questions if you have any. We're already receiving several, which is great. And now I will turn it over to Dr. Freebird.
Thank you, Cindy, and thank you to the Child Neurology Foundation for this opportunity, especially to let someone who is not a neurologist participate in this exciting seminar. And I'm going to be speaking more about the communication aspect of the disclosure of SUDEP and other difficult news. The objectives that I wanted to explore today are to think through why this is hard to do and to identify specific strategies that will help on both sides of the equation, and by that I mean on the family and caregiver side as well as on the provider side, so that outstanding communication can really occur to help everyone navigate these difficult settings so that we can get to a point of common understanding. The poll question, don't answer just yet, is have you discussed SUDEP with your medical provider? Yes, no, or I don't remember. So go ahead and vote now. Have you discussed SUDEP with your medical provider? I'll give you a few seconds to answer. Like answers are still coming in here. And Cindy talked a little bit about the survey responses at the beginning, and we will explore that in a little bit more general detail here, but it looks like 2/3 of our respondents have not, is what I'm seeing on the poll there. I might have gone through that a little too fast. So that kind of mirrors what we know. And we know there are a lot of reasons from the survey that Cindy mentioned that SUDEP is not discussed. There's discomfort on both sides of the equation. And one of the things that I want to point to is that for caregivers, a big contributor is that people worry, physicians and others worry that the information could be negatively impact a child or a family in terms of quality of life, mood, and hope. And I think that's one of the biggest barriers to disclosure of bad news in general. But what we know from families, and Cindy showed a little of this data, is that you want to hear about SUDEP, and having heard from Dr. Bucholter about the fact that this is not as uncommon as we thought. If this is 1 in 1,000, being honest and open about that is really important. These quotes that you see on the screen here are directly from Mike and Mary Ann Stanton, to whom I'm very grateful, Danny's parents, and you'll hear more about the Danny Did Foundation, but I had the opportunity to speak with them about their experience with Danny, and I asked them what they would have wanted to have heard from medical providers. And my guess is for caregivers on the phone that this reflects probably a large part of your feelings as well. And I would just encourage that we read the words, and then for the providers on the webinar today to remember that this is probably what people are thinking, especially this last point, that delivery of this information should be standard of care. And I think we saw in the guidelines that were just released earlier this year that that is the direction that we are moving. The survey told us that parents are worried about this, and your survey here today told you that people are worried about it. But despite that worry, most people are not learning about this information from where you might hope that they would, namely from the epilepsy specialists who are caring for your children. So most people think that their child is at risk and want more information because it will actually help you make a difference in how well you take care of your child. Another interesting thing here is that we talk a little bit about risk in terms of high risk maybe being sometime when you would want to push the conversation. But what we hear from families is that most people want to be told regardless of what that risk is, and most people want to be told early in their child's disease trajectory, maybe at the first appointment even. Some folks don't want to know right up front, but would want to know at that first follow-up appointment after diagnosis. So families are telling us that they don't want to wait to hear about this news, and that they feel that it's important that they learn. And why does it matter? Again, these are more quotes from Mike and Mary Ann Stanton, and probably again reflect what people on the phone might say if we gave you the microphones. But people who have been through this experience, Mike and Mary Ann, felt that it would have allowed them to entertain options that might have helped Danny, but more so that they feel that as parents it's their job to protect their child, and they need all the information they can put their hands on in order to do the best job doing that. It might not have changed the outcome, but it would have left them without feeling quite so blindsided, despite thinking that they had done everything possible they could to take care of their son. There are, though, a lot of challenges, and obviously we know that's true because otherwise good communication would be occurring 100% of the time, and we've just been talking about the fact that it doesn't. And I think there's a lot of things we could talk about as potential barriers, but some of the things that I wanted to highlight here are that obviously children who are going through these illnesses themselves and adolescents are going through their own developmental changes, and they may or may not be willing to open up themselves to their care providers. A lot of times, despite the fact that we've hopefully been changing the paradigm about using jargon with families, we know that providers still use a lot of big words, and families are sometimes reluctant to ask what that means for fear of feeling stupid or feeling like they should already know. And physicians differ in how they want to give information, and parents differ in how they want to receive information. And so most family caregivers feel responsible for that information, but they lack authority within the dyad of the healthcare provider family dynamic that we're in. So many challenges. And I think this really is the core, in that it's a balance of expertise. As a physician, I am a medical professional, and as a child neurologist, your child neurologist has the medical know-how to take care of your child with a seizure, and so in some sense is the holder of the cards about SUDEP and about other medical information that's important. But we need to balance that with the expertise that the family brings when they come. The family is a functioning unit and has a role in protecting their child and protecting that unit, and brings to the table unique knowledge about their child. So I think if we can recognize that from both sides so that we're not putting too much burden on either side of the equation, we can get to a more partnered approach in how we give and receive information. So one of the things I wanted to do is just be a little bit practical about how to come to this partnership effectively if you are a caregiver. And I know we have both providers and caregivers on the phone. This is directed more toward caregivers. Some things you might think about when you're going to a child's appointment or to your own appointment, if this is you, is to write down your questions and concerns in advance. I think sometimes we think we'll remember everything, but I know for myself even, knowledge sometimes flies out of my head when I'm in a higher stress situation. Also good to bring your posse with you. That may or may not be biological family members, but who are the people that you feel safe around who help you make decisions? And if you are going into a situation where bad news is likely to be delivered, and we'll talk about that in a few minutes, I would suggest that you have a designated driver. I am trained partly as a pediatric hematology oncology physician, and I once had a father talk to me after his child was diagnosed with cancer, and he told me that it felt like he had been sitting in a bar and had had 12 drinks served to him when he walked out of the office to drive home. He felt more impaired having been given bad news about his child than he would have had he been drinking. And I think that's something that we don't take seriously enough when people are given difficult news, that it alters your ability to focus and concentrate. And so just being safe is really important. And as a caregiver, explain what you want up front, or as a patient, explain what you want up front. Explain how you would like to hear information. Maybe somebody's asked you that, but if they haven't, just volunteer. How do you process information and what do you want to know? And then be sure to make a follow-up appointment to get your questions addressed, especially with a new diagnosis or something that's difficult to hear. That's not too much to ask for, and providers are generally happy to accommodate that. And I think that's important because it's realistic and normal to know that you're just not going to absorb everything that you need to know at one visit. A lot of times families will hear the information that their child has a seizure disorder and they may not remember anything else after that. It's normal to need to have things repeated. It's normal to process things differently. Parents, men and women, process things differently. Two different parents process things differently. The child and the parent will process differently, and we all learn in different ways. So knowing how you are as a learner is also helpful. If you would do better with a picture, ask your doctor or your child's doctor to draw you a picture, and maybe that will help you remember things better. So everybody has a different learning style, and we need to remember that. And we talk a lot on the provider side about how to deliver bad news well, and I'll mention that in a minute. But I think there's also potentially some things we could do on the caregiver side to receive difficult news well. And I think if you can go into an encounter being open to the fact that the provider does not want to be giving you difficult information, but you're there to learn and that you want this information. So leaning into the conversation, being willing to hear it, will help on both sides as well. Expect that you're going to be emotional, and this goes for providers. Expect that people in the room with you are going to be emotional, and that's just going to be a normal part of the process. If you've gotten difficult news about yourself, about your child, maybe you need a mental health day, a rest day, or some stress-relieving activities. Don't just expect yourself to go right back to work or to school and handle things normally. And then it's also very normal, and your care providers should be open to you getting information from other sources. It's perfectly fine to get a second opinion if you've had a new diagnosis or difficult information. And it's also, in this day and age, everyone jumps on the internet, but I would just caution you not to put more stock in Dr. Google than you put in your care provider. So it's okay to look things up, but we would encourage you to bring those things back to your care provider and discuss them. In terms of saying the right words, I think this is something that care providers worry about a lot on both sides, but particularly from the medical side. I was taught, particularly as a palliative care doctor, that words are very, very important, that they matter just as much as medical instruments, and that parents are going to remember everything that I say. And that can be a barrier to having an open conversation with a family. If I'm afraid that every word I'm going to say is potentially hurtful, I'm going to be very careful. But what we know and what parents tell us is that actually style matters more. And I would say this goes for the listener too. So if you're listening to bad news, you might not be able to get all all of your words out, but your style of being present, being sincere, and listening can go a long way to improving that communication dynamic. The other thing that I would say to care providers who are listening is that we know from the literature as well that even though words matter and even though you want to pick those right words, don't let that get in the way of delivering the news, because most families are very forgiving. And if you said something in a way that you wish you hadn't, just go back and say, gosh, I wish I hadn't said it that way. Let me re-explain. And most families will be fine with that. So we shouldn't be so afraid of words that we are not having the conversations we need to have. Remember, too, that no one really wants to be the bearer of bad news, and so care providers are not there to hurt you. The purpose is to empower and educate, and I think if families can remember that, people on the care provider side might be a little less afraid to deliver that information. So the messenger requests that he please not be shot. A little humor is always important, I think. A common thing that I just want to mention is the disclosure paradigm that we get into sometimes when parents are interested in information but maybe reluctant for us to share this directly with their children. And I would encourage you as parents, or if you're an adolescent yourself, to think through that. It doesn't mean that everybody needs to be told everything all the time up front, but developing a relationship as a child neurologist with your child or adolescent patient is really important. And most of the time, disclosure can be a very hopeful and empowering part of the relationship. We know from literature as well as anecdotal experience that actually being honest in a relationship does not destroy hope, which is of course what everyone worries about, but creates it. And that when we don't talk to children and we don't include them in these conversations, what they're imagining is sometimes worse from what is actually happening. So when we are secretive and we avoid things, we can make them worry more than maybe they need to. We also know that empowering children to participate in their own illness and their recovery gives them coping skills, it improves their adherence, and as they transition out of childhood into adolescence, they become more responsible for their own health care, which of course is part of the goal. So if I could exhort you to be willing as parents or your caregivers of children with these issues, please allow them to participate in the conversation. Now, obviously, these conversations need to be at developmentally appropriate levels, and children may or may not want to participate. So I'm not suggesting that we force children who are not interested in being part of the conversation. But every child, no matter how young, can express some preferences about their treatment and care decisions. And so helping them understand what's happening to them actually makes them more comfortable and less anxious. This is a 6-step strategy called the SPIKE strategy, which is very helpful in terms of learning how to deliver difficult information. And I would encourage you, we don't have time to go into it in depth today, but to just look it up and think about it as both a strategy to give as well as to receive information. And what the SPIKE strategy does is it helps providers think through different aspects of the news and how it should be delivered in terms of making sure that the setting is right, making sure that we understand what families want to know and how they want to know it, actually having an invitation from families to deliver information, imparting the knowledge that we have and understanding the knowledge that they bring to the table as well, doing this empathically, and then also concluding any encounter with a strategy and a summary so people are not walking out without any sort of plan as they leave the office. So if you're a caregiver of a child, know that perhaps this is what your caregiver is thinking through as he or she is meeting with you, and maybe expect some of these things to happen. We also encourage providers to fire what we call warning shots. So if you're in a situation where you're giving difficult news, make sure that the recipient has a moment to prepare. And these are some words that we use to provide that warning shot. And these, you can meld them to words that you're more comfortable with, but sometimes if you allow families a moment to realize that you're going to say something difficult, it can go over better. So what you should expect if you are a provider or a child who's in an office receiving difficult information is that people should check in with you. Your provider should check in with you. Are you following? Are you understanding? And we encourage providers not to do this with yes/no questions, but to actually have you repeat the information, not because they are trying to make you feel stupid, but to make sure that you are actually understanding the gist of what you are being told. You should expect that people will summarize that information. You should expect a chance to ask any questions, and you should leave with a clear plan as well as who's going to be doing what. So on the provider side, if you've accomplished these goals with folks in your office, you've done a great job in achieving good communication. Just a quick moment about new life-threatening diagnoses. Sometimes, we're talking about a remote or not so remote risk of SUDEP, but sometimes child neurologists and others are in a position of providing very difficult information, and we worry about how these diagnoses will affect families. But again, I would exhort that honesty about prognosis allows people to recognize what is ahead, and so if we lean into these conversations from both directions, we can make thoughtful plans for care, and we actually have data that shows that honest conversations preserve hope and are not harmful to adult patients or to children and their parents. It is upsetting, but that fear of emotion on the side of the parent or the side of the provider should not preclude that conversation, because even people who get very upset still say that they want the information, and that maybe relief of uncertainty can be helpful. So sometimes a bad diagnosis, as hard as that is, at least is something that we can start to work toward a plan around. Timing is everything, and unfortunately in medicine we're a lot of times behind the 8 ball here. So waiting until the end is not helpful for anyone. The earlier we have these conversations, the more families can make decisions and participate in their health care in a way that fits with their family's goals and values. So this is language that you as a child or a caregiver could use in talking to your provider. What do you think it's important for us to know? This might help sort of prompt your provider to communicate with you in a way that's meaningful to you, or to just fire the shot that it would be helpful to talk about what might be ahead for my child if you're sensing that your provider is reluctant to have that conversation. And if SUDEP is, now that you know about it, if it's not being mentioned, you might mention it yourself and say, it would be helpful for me to talk about what it might mean for our future. So just giving you some concrete suggestions. And when you are in a situation where you're receiving bad prognosis as a caregiver, think about how you would like to receive that information and convey that to your care provider. Are you a numbers person? Are you somebody who wants to know statistics? Are you somebody who wants to plan? Are you a planner? Would it help you to know what your family's life is going to actually look like in the time ahead, or not? Some people don't want to know that, and that's perfectly fine, but just expect that it's going to be an uncertain time for you and your family. So as you're entering these conversations, think about your goals of care for your family. This is a good conversation perhaps to have before you come back to your follow-up visit. What are you as a family hoping for? Everyone's hoping for a miracle, that your child is perfectly well, that SUDEP never happens, and that nothing bad happens to your family. But what else are you hoping for beyond that? And consider both achievable as well as long-term goals that balance both your goals as well as that of your child. And finally, I would just put in a plug for what we call transdisciplinary approaches to this sort of thing. We do better as a group in the sense that the more disciplines we have involved, the more we can make sure that everyone's needs are being met. And there are other providers on healthcare teams that can be helpful, especially for children, to help them express their own needs. I've listed a few of them here, as well as for families. And for care providers, this can be very helpful as well, to have a team behind you as you are working with a family. And just a plug, because I am a palliative care doctor, to suggest that if your child is seriously ill or if your patient has a potentially life-threatening condition, think about a palliative care consult early, not because palliative care is end of life, because it's not, but this is actually the beginning of quality of life for many families. So that's just a plug, but I'll stop there. And again, thank you for your attention, and we're happy to answer questions at the end as well.
Thank you, Dr. Freebird. That's very helpful. At this time, I would like to turn it over to our next speaker, Tom Stanton.
Thanks, Cindy. I want to start out by introducing everybody to my nephew, Danny, who you can see here on the screen with his 3 siblings. Danny was an affectionate and athletic little guy who loved baseball and roughhousing with his siblings, and he was an awesome little kid. Danny also had epilepsy, After he had his first seizure at age 2, his parents witnessed fewer than 5 seizures over the next 2 years or so. So he was fairly well controlled by medication, and he had no other health complications. Fast forward to a few months before his 5th birthday, and Danny was found lifeless in his bottom bunk bed on December 12th of 2009, which was a Saturday morning. He had visited his neurologist on the Tuesday prior, where he received a slight modification to his medication due to his weight gain and the assurance that his treatment was on the right path. After Danny died, my brother Mike and his wife Marianne realized how little they knew about the condition that took Danny's life. And so with the mission to prevent deaths caused by seizures, they started the Danny Did Foundation. And the name of Danny Did comes from the last line of Danny's obituary, which was written by his dad, and that read, "Please go and enjoy your life, Danny Did." So today, the DDF acts as Danny's continued presence in the world. We work to increase awareness about epilepsy and the risks that accompany epilepsy, and to increase awareness about technologies that detect or predict seizures. So open dialogue between doctors and parents is really important, as Dr. Freebert just alluded to. As many of you know firsthand, parents digest difficult information all the time. It is our responsibility to consume that information and to then shape the best treatment plan possible. We think that information about SUDEP is best delivered by medical professionals. That said, if families aren't hearing about SUDEP from a doctor, they are left with a dangerous blind spot. At Danny Did, we work to fill that communication gap and to educate families by sharing Danny's story and by talking about the risk of mortality in epilepsy. Our strategy is to talk about SUDEP within the context of all the risks that accompany epilepsy. So, for example, risks related to falls and injuries, swimming, bathing, driving, head trauma. If a parent hears about SUDEP within this larger safety context, then that parent is equipped to ask questions and to learn where their child falls within the risk spectrum. So our message for doctors is we need better communication, and we encourage doctors to talk with patients and parents about SUDEP. And tied to that, we feel it's really important to educate every family. Danny only had 6 known seizures, and some doctors may have assigned him as a low-risk patient. So until the exact cause of SUDEP is determined, all families should be made aware of this risk. Once a parent learns about the risk of SUDEP, a logical next question is, how can we reduce that risk? On the screen, you can see actions patients and parents can take: increased awareness by the public, working towards maximum seizure control, lifestyle choices that reduce stress, keeping regular visits with the doctor, considering monitoring devices, having knowledge of seizure first aid, and advocating for SUDEP research. Danny Did created a brochure that overviews the range of safety risks that accompany seizures, specifically for children. The purpose is to responsibly introduce the risk of SUDEP and to answer common questions around it. This brochure is available on our website, dannydid.org, and we also provide it to doctors' offices and epilepsy centers who want to distribute it, so that a parent has something tangible to take home and review after they hear about SUDEP. So now we have a poll question. Don't answer just yet. The question is, do you currently use a seizure monitoring device in your home? And the responses are rolling in here. It looks like about a quarter of people do, and the rest do not. So that's I'm glad we can share some information about this potential resource. A couple more responses coming in, but it looks like about 80-20 do not. Okay, so a question that Danny's parents had after he died was, how is there no system that could have alerted them during a seizure, that last seizure? So now a focus for Danny Did is talking about devices and technologies that complement medication, surgery, and diet as a part of a patient's treatment plan. And we really view devices as another resource in a caretaker's toolkit. A device doesn't replace a parent's instincts, but it can help to keep your loved one safer by giving families a chance at early intervention when a seizure occurs. The value of early intervention is simple. If you are present, you can take action. You have a chance. Dr. Buckhalter alluded to this in his slide on supervision. A monitoring system can also provide peace of mind to parents, so many of whom are desperate for a decent night's sleep. So we recommend working through a checklist of considerations before picking a monitoring system. This is a regular question that we get, is which system works best for us or would work best for us. So we partnered with the Child Neurology Foundation to create a brochure that lays out 5 important factors, which I'll briefly mention. The first being, determine which method is best to detect your child's seizure type. So for example, movement versus heart rate. To think through what are your goals for the device. Do you want to be alerted? Do you want to track how often seizures occur? And then ask, does that system achieve this for you? Third is to consider the appropriateness of the device. So for example, is it comfortable for your child to wear? Are there age or weight restrictions? Fourth, determining the ease and use of setup. And fifth, determining the costs involved. And this information from this brochure is available on both the Danny Did and the Child Neurology Foundation websites. So next I want to just briefly talk through examples of device systems. It's not easy, we know, to stay current on all the technology that's out there, and so this is an area where Danny Did can be a resource. This slide talks through a range of general categories within the device space. There are systems that monitor and alarm for seizure-like activity that occurs during sleep. There are systems that are worn and can monitor for activity both day and night. Systems that record and store seizure activity. Systems that are implanted via surgery, such as VNS. And then app-based technologies that aim to track seizure activity with no alerting function. If you have questions about specific products, we do have a page on our website that addresses some of the options out there, or you can feel free to reach us by email. Now, I want to give a quick plug for a program we have to help families who have researched a device system that they think can be helpful, but if cost is a barrier, you can submit a grant application to Danny Did, and we'll do our best to help. And that information is at dannydid.org. Then my last slide, I just want to give a quick plug for a meeting called Partners Against Mortality in Epilepsy, or PAMI. PAMI is a meeting of scientists, clinicians, patient advocates, and families who are affected by epilepsy with the purpose to improve patient education, to contribute to increased communication and disclosure by healthcare providers, and to encourage continued advocacy by patients and families. And so the next PAMI is going to be in June of next year in Virginia, and we offer travel grants if parents or even some doctors are wanting to be there, but cost is a barrier. So we hope you'll look into joining us. So with that, I thank you, and if we can be assistance to anybody on this webinar, please reach out to let us know.
Thank you, Tom. That's very helpful. And I would like to turn it over to our next speaker, which is Margaret Story.
Hi, everyone. My name is Margaret Story, and I'm on the board of directors of the Danny Did Foundation, and I'm very grateful to be able to be part of this excellent seminar today. I'm also a parent. I'm a parent of Josie, who is age 14, She has Aicardi syndrome. This is one of the rare genetic syndromes of epilepsy. It features early onset intractable seizures, usually in the form of infantile spasms, that then generally transform over the life of the patient. Josie currently has a mixed seizure type. She usually has spasms, clusters of spasms, but she also has tonic seizures, and these occur almost entirely in association with sleep, either at night or in the daytime. I first learned about SUDEP when Josie was 2, but I didn't know it really at first. One morning, our early intervention physical therapist shared the news that a boy in our town who was not much older than Josie had died earlier that week. She was his PT as well, and he and Josie also happened to share a neurologist. I knew that he had had seizures, and it was devastating to hear that he died, but the PT didn't know or didn't share with me, which would have been appropriate, of course, the cause of his death. It was only at our next neurologist appointment that I put 2 and 2 together. Our doctor must have been both devastated by the loss of his patient and perhaps alerted to the need to bring up the question of mortality, because he started that conversation by introducing SUDEP for the first time. I've always assumed that the little boy's death had prompted him to help other families learn about this danger. I was grateful, of course, as well as scared. But I'd been scared about Josie for a long time. The news of SUDEP just gave a name to one aspect of the raft of fears her illness brought with it. Now that Josie is 14, I can see that there was a pattern to how I approached and accommodated new information about her illness, and especially mortality risks. In the early days, I really was not able to integrate this very well. I did not want to think about it, nor did I want to accept it. I don't think that this is rare or unusual. Most parents do not want to grapple with this kind of reality. I mostly kept it tucked away in my mind, something that I would occasionally pull out to examine for as long as I could tolerate it. And I suspect that the parents in our audience know what I'm talking about. Now, as the years went by, I could do this examination for longer periods of time, in part because I got more comfortable with it, but also in part because I began to experience, as an outsider, the death of the children of my friends whom I'd come to know as fellow travelers in the world of complex medical kids. By the time Josie was 10, I knew 7 families personally whose children had died from various complications of their diseases, many of them seizure-related. In the same period of time, many girls with Aicardi syndrome, who I only knew virtually on Facebook, had also passed away. Now, our reality is not typical. Josie's is a rare syndrome, and it has known mortality risks. So we are in a particular sort of category. But what I want to emphasize, both to families and really to providers, is that in the end, no matter how the diagnosis comes, epilepsy is a life-changing diagnosis. It is, no matter what, serious. And we need our neurologists to help us understand mortality within epilepsy. Trust me when I say that most parents can and do come to terms with SUDEP. It may take a while, it may take different forms, but they can adjust to knowledge like this. We need only to reflect on the ways that most parents accommodate and digest other difficult news, setbacks, disappointing EEGs, troubling MRIs, to know how resilient parents can be. This is what it is to be the parent of a child with a chronic condition. What parents need is not shelter. What they need is help in knowing how to live well with the risk. Now, how to use this information for care at home is an interesting question. The fact that I did not want to look the risk of death squarely in the face early on and really accommodate it right away did not mean that our approach to Josie's care was insensitive to this reality. In all honesty, for many years, every seizure brought with it the sensation of the fragility of her life. And the various dangers that hung around her all the time only reinforced this. Will she fall out of a chair? Will she knock herself out when she slams her head down on the table with a seizure? What helmet should we buy? What kind of bed should we have to protect her? Will she choke to death on her food? All of these are ever present. What's different about SUDEP is that there weren't answers to the question. The key challenge was there was no help on offer, no advice about strategies to prevent it, no monitors provided to support us in our care for her at home. We could buy the proper bed, we could find the proper helmet. What we couldn't do was figure this out, and this was and is frankly ridiculous, and something that we as a community must deal with. And of course things have changed really remarkably since Josie was little, but we still need champions in the clinical and research communities to demand that effective, practical, affordable, insurance-covered seizure alert devices become part of the standard of care, just as blood sugar monitors and CPAP devices are standards of care for patients with diabetes or apnea. The first thing I think people should do when first learning about SUDEP is, of course, to speak to your neurologist if your neurologist hasn't been the person to bring this up with you. But then I really do think that there are some wonderful resources both at DannyDid.org and the SUDEP Institute online where you can learn more about SUDEP, get really reliable information about those available monitoring devices, as Tom pointed out, and guidance about how to choose them. I'd also say that, like with all things in parenting a child with a chronic health condition, you have to strike the right balance, the best balance in guarding against SUDEP for your peace of mind, and to balance that with your child's health and happiness in the everyday and what's reasonable in a home setting. And finally, I would say that I think everyone should ask their doctor about pulse oximetry monitoring if the consumer monitoring devices don't fit your child's needs. A pulse ox can be configured for use in the home and may be the thing that provides a reasonable amount of protection because it can detect when a child's O2 levels have dropped. This is good not just for reducing the risk of SUDEP because it allows us to intervene. You know, it gives us that chance, as Tom was talking about, but for offering assistance to a child in the midst of a prolonged seizure or other medical event during the night, even if it's not going to result in SUDEP. This is, in the most basic terms, what parents want and need to know that they can do to help their baby or child in their time of need if that child is unable to alert us to that need themselves. Thank you so much.
Thank you, Margaret. Thank you for sharing your and Josie's story. And thank you to all our speakers. At this time, I'm going to begin with the question and answer session, and you can still submit questions. We have a few more minutes here to take those. I'm going to start with we have a question, and Jeff, I'm going to give this one to you. I don't think my child is having seizures at night, but should parents monitor their child overnight to determine if they are having seizures? Are there usually signs that a person's having seizures at night, and do the people or children remember them?
So the answers are yes, yes, and no. It is a good idea to know if a child is having seizures during sleep. In the best of all worlds, there's no indication that a child's having seizures in sleep, and if you want to reassure yourself, one could spend the night in the room or set up a camera for reassurance. The second yes was very frequently there are signs that individuals have seizures during sleep, and parents, particularly moms, have uncanny senses of hearing. To hear sounds that aren't quite right, to find excessive drooling on the pillow, blood from biting a tongue, nightstand that's knocked down, child on floor, blankets in disarray. So frequently there are indicators that that someone's had a seizure during sleep, but certainly not always. And what was the last part, Cindy?
Do the children or adults remember having them?
Most often not. There are some examples where folks will know and it's frequently not so much the memory of the seizure itself, but the memory of, or waking up and knowing that something isn't right. For example, muscles being sore due to having a tonic-clonic seizure.
Great, thank you. Leanne shared with us that her 18-year-old son died of SUDEP, and he would not have been considered high risk. And even though he was having breakthrough seizures, their doctors did not increase the medication. And she wanted to relay to the professionals on the call not to minimize the condition. And that sort of leads to another question from Jenna. And Jeff, I think this goes to you as well. How normal is it to keep increasing meds without seeing a patient? She describes her son's situation, and basically that rather than seeing him, his meds have been changed several times. The past 2 months, the meds have been up twice without even being seen. Is that normal, and should she request to see her doctor?
Sure. And I'd like to respond to both. The whole issue of what is low risk, and we need to just say that what we are talking about today has come to our attention because of the most severe consequence of seizures, SUDEP, and the community has been alerted to it, and what we've identified are frequent generalized tonic-clonic seizures. And so that's where most of the thinking is in the community. The whole issue of low risk is something that is there and will bubble up to the surface in time. And by that I mean, first of all, for epilepsy syndromes in children that we think are low risk, like childhood absence epilepsy, true petit mal, I know of no reports of death associated with it due to seizures. So the reason for talking about SUDEP in that almost zero risk situation is reassurance, because as you've demonstrated, people come into the office knowing about SUDEP from the internet. So there's that issue of low or no risk. There's the situation of low risk due to very few seizures. And what we've learned, and those of us in this community know and sit with families who have suffered the death of a loved one after very few seizures, that SUDEP can occur after 1 or 2 or 3 or 4 seizures. And so low risk is not no risk. And then that brings us to disclosure. What is one of the reasons that we should, as care providers, always discuss SUDEP in the first or the second visit? And that is because when tragedies happen, one of the common things that the affected will say is, the doctor never told me about it. And this is a psychological damage that loved ones never get over. Jean Connolly, who was one of the moms who lost her son Chris and really jump-started the SUDEP movement in the States, will say this to us, and she taught me. So I think it's very, very important to bring up the possibility of SUDEP for all those reasons in low-risk situations. The question about increasing medications by phone, is it normal? And the answer to that is, and of course I wouldn't presume to try and second-guess a situation that I don't know about, but the answer is it is frequently very normal, because whereas the provider can communicate with the family every week or every 2 weeks and be aggressive about increasing medication, that may not be available when the next appointment is 3 months down the line. So in terms of being aggressive about intervention, yes, it's fine and a good idea. Where it fails is if the family and the patient need to talk to the care provider about some of the issues that can only be done face-to-face.
Great, thank you. I'm going to take 2 more questions. The next one I'm going to give to Tom, although Jesse may want to weigh in as well. And this is from Mary, and her question is there a best recommended monitor to alert of nighttime seizures? And there was also one from Amy along the same lines of, are these devices covered by insurance, and roughly how expensive are they?
Great. So the question of which one is the best is really unique to the situation. So we always encourage families to go through that checklist of things to consider. And so, for example, in this situation, if nocturnal seizures are the biggest area of concern, to look at the products that are out there that are designed for activity that occurs during sleep. So that is one kind of way to whittle down your list of priorities and focus on systems that look at seizures that happen during sleep. And the second part of that question, Cindy?
Was roughly how expensive are they, and are they covered by insurance?
So there's a pretty big range. You can find, for example, a low-tech anti-suffocation pillow that's still focused on safety for $100 or $150, and then there are systems that get up into depending on which features you choose, around $1,500 or so. So it's a big range. The question of insurance is typically not, although we definitely encourage families to investigate, to ask their insurance companies, and to push for coverage, to ask doctors and nurses about insurance coverage. But typically there's not a lot of insurance coverage because these are mainly considered consumer devices. And when you get into the realm of implanted technologies like VNS or RNS, that changes, and there typically is insurance coverage. But for the non-invasive options right now, there's not a lot in the way of insurance coverage.
Great, thank you, Tom. Final question is going to go to Sarah, or Dr. Freebert. What do I do if my doctor tells me not to worry about SUDEP, even though I know from the data that my child is at risk?
That's a great question. I think from today's presentation, we know that people are worried, and I think if somebody is dismissing your worry out of hand, I would take the opportunity to explain that this is an important worry to you, and try to understand what the perspective of the healthcare provider is who's telling you that. If you are open to the conversation and you're putting yourself out there saying, I am worried about that and I'm searching for more information, I would hope that you would get a collaborative response to that question. I think that worry is worry regardless of statistics, and when families come forward and say that this is something that they're concerned about, that concern should be heard loud and clear. What your provider may be trying to say is that the worry is low, or the risk is low, and so maybe trying to be reassuring by saying that this is not something that's likely to affect your child. But I think I would, in a sense, just be direct and say that you've learned that this is more common than we think, and this clearly is a worry, and you'd like to have an open and honest conversation about that. I would suspect that the caregiver will respond appropriately to that. If not, and I'm not casting aspersions on anyone, but I think finding a care provider that you can work with, whom you trust, and who can have open and honest conversation with you is a really huge key to successful management of your child's illness. And so it may be that you need to think about that in terms of evaluating your child's care team.
Great, thank you, Dr. Faber. And at this time, we've gone a little bit over, but so I want to close the webinar, and I want to thank all our panelists, our partners, sponsors, and of course you, our audience. This webinar has been recorded and will be available by November 21st from the Child Neurology Foundation website. You can access the recording and learn more about the Child Neurology Foundation at childneurologyfoundation.org and /SUDEP for the SUDEP specific material. When I close this webinar, you'll be prompted with a brief survey. We ask that you please complete the survey to help us continue to improve our programs. And once you complete the survey, you will be provided a link to download both the Considering a Seizure Alert Device brochure as well as the Spike Strategy reference card. So thank you again, and I wish you all a great afternoon.